This is Herb Kressel, editor of Radiology, and welcome to the March 2017 podcast. This month, we have a special extended panel discussion. We're publishing 3 separate articles on gadolinium retention and have a panel discussion related to the 3 articles. So joining us will be Dr. Tim Deneke from the Virchow campus of Charité Medical Center in Berlin, who with his colleagues wrote an article entitled, "Is there long-term T1 weighted signal intensity changes in the central nervous system after gadolinic acid exposure?" This is an agent that we have not learned about the gadolinium deposition after use. We'll also be speaking with Dr. Alexander Radbruch of the Cancer Center in Heidelberg, who with his colleagues wrote a provocative paper entitled "No Signal Intensity Increase in the Dentate Nucleus on Unenhanced T1 Weighted MR Images After More Than 20 Serial Injections of Macrocyclic Gadolinium-Based Agents." And the third author joining us is Dr. Paul Evans, who is the director of non-clinical science, head of non-clinical science at GE Healthcare in Amersham. And he and his colleagues did a longitudinal study entitled "Clearance of Gadolinium from the Brain with No Pathological Effects After Repeated Administration of Omniscan in Healthy Rats, an Analytic and Histological Study." To round out our panel, we're very, very fortunate to be able to have Dr. Manny Kanal, Professor of Radiology and Director of MRI Services at the University of Pittsburgh, and Dr. Mike Tweedle, Professor of Radiology at Ohio State University. And Dr. Tweedle is a chemist who has been an active investigator and inventor of gadolinium-based contrast, and Dr. Kanal has decades of experience and expertise in issues related to MR safety. This podcast is a little bit longer than our normal ones, but I assure you it will be worth your while. Thank you. Next, my colleague, Dr. Albert DeRoos, will interview Professor Bjorn Freibe of the Otto von Goethe University in Magdeburg, Germany. Dr. Freibe and colleagues wrote a manuscript entitled "Impact of In Vivo High Field and Ultra High Field MRI on DNA Double-Strand Break Formation in Human Lymphocytes." This subject has been quite controversial and created a very significant stir in European radiology and cardiology, and I think you'll find this discussion quite informative. Thank you for your interest in the podcast. We look forward to hearing from you. This is Herb Kressel, editor of Radiology, and welcome to a special edition of the Radiology podcast. In this month's, the March issue of Radiology, we have 3 fascinating articles dealing with the issue of gadolinium deposition following administration of gadolinium-based contrast agents. And to help us understand the papers and their implications, we have the authors of the 3 papers and 2 discussants who have written editorials in our journal and reviewed many of the papers on contrast agents. So joining us today are Dr. Manny Kanal, Professor of Radiology and Director of MRI Services at the University of Pittsburgh. Welcome, Dr. Kanal. Thanks for joining us.
My pleasure. Thank you for inviting me.
And his colleague in the editorial, although not at the same institution, is Dr. Mike Tweedle, professor of radiology at Ohio State University. Thanks for joining us, Dr. Tweedle.
Thank you, Dr. Cuss.
And now moving across the pond, Dr. Denneke, who is attending faculty at the Virchow campus of Charité Medical Center in Berlin. Welcome, Dr. Denneke.
Hello, thanks for inviting me.
Sure. And a return visitor, Dr. Alexander Radbruch, who's a senior attending at the German Cancer Research Center in the Department of Radiology in Heidelberg, Germany. Welcome, Dr. Radbruch.
It's a pleasure to be here. Thank you for inviting me.
Sure. And a newcomer to our podcast is Dr. Evans, head of non-clinical services at GE Healthcare Life Sciences in Amersham, UK. Welcome, Dr. Evans.
Hi, thanks for the invitation. It's great to be here.
Sure. Okay, why don't we begin? Dr. Canal, maybe you could set the stage for us. Where are we in our understanding of gadolinium deposition following gadolinium-based contrast administration?
Well, it's been almost 3 years since Dr. Kanda came out with his first revelation of the connection between gadolinium-based contrast agents and intracranial, at least intracranial parenchymal retention. We've learned so much, but at the same time, we've learned so little in the interim. We do know that there's retention that occurs with essentially all these agents, but seems to occur more or even significantly more with the linear agents than with the macrocyclic agents. We've learned that there's a possibility of washout, but there seems to be some conflicting data in that sense as well. We've learned that whether or not we see it on T1 shortening on images, Dr. Murata and others have now found that there is significant, definite retention for all agents, regardless of their makeup, whether they're macrocyclic or linear. And perhaps most importantly is we still have no idea what the clinical relevance, if any, is of this finding.
Well, thank you. That sort of it's quite a story. We've learned a lot, and yet we still seem to be at the beginning. Dr. Denneke, you and your colleagues authored the first paper we'll discuss. Is there long-term T1-weighted signal intensity changes in the central nervous system after gadoxetic acid exposure? And so it's kind of an interesting problem to look at the brains in patients receiving a liver agent. So what was the impetus for the study, and how did you actually acquire head exams in patients receiving gadoxetic acid?
Yeah, well, motivation for this study was, of course, to see whether in this, it was virtually the last contrast agent of which we didn't know whether there would be or not some accumulation in the brain. And as we work a lot with liver imaging here and a lot with this special agent, we wanted to perform this study. And as you said, it was quite difficult. We had to do extra scans, and we couldn't go in a retrospective fashion back to gadolinium naive scans, because those patients which we enrolled were all liver patients, and only occasionally there has been some brain scan, but in the majority of the patients not.
I see. So they were all liver patients. Many or most of them were for surveillance for hepatocellular cancer, and some had suspicions of metastatic disease. Is that correct?
That's correct, but many patients as well, especially when we go to those who had many follow-up scans every now and then with Primovist again and again. Those patients are from special surveillance programs, cirrhosis, a few, but also patients with neuroendocrine tumors, which are followed with this specific contrast agent, and as well from our minimally invasive treated patients with liver tumors.
Okay, now you had a control group. You had 91 patients that received the gadoxetic acid, and you had a control group. How was the control group acquired?
We made a control group because we didn't have the gadolinium naive baseline scan, and that's why we thought it would be a good idea to have a control group to be compared. And the control group, of course, had to be gadolinium naive as well. And we casted those patients from neuroradiologic scheduled exams.
Okay, so for these patients, you acquired an unenhanced T1 weighted scan before administering the contrast agents.
Exactly.
Okay, and then tell us about the exclusion criteria. You excluded patients that had more than 2 prior MRIs with macrocyclics, but you also excluded patients that had any prior linear agent. Is that correct?
That's correct. I thought that would be important to not have any confounding factors in there. I didn't.
Okay. And where did the number of 2 come from for the macrocyclics?
On the one hand, we did want to exclude any gadolinium-based contrast agents, but on the other hand, we wanted to have a study cohort large enough. And then we ended up with 2 estimating to approach a number of 100 patients.
So you divided them into 3 groups, and the readers can see that you had one that had lower levels of exposure, sort of mid, and then the most number of previous exposures. And what was sort of the average for the 3 groups?
Yeah, well, this is kind of an arbitrary intervention in this study.
Yeah.
To have those 3 groups. I think the most important point is the correlation of the entire group of gadolinium EOB exposed patients with the number of applications. But that's the mathematically more important part. Okay. But on the other hand, I wanted to get an idea of the clinical situation of the patient when he comes to me, and also wanted to have 3 groups equally large. So I divided our cohort, which is 91 patients, by 3, and looked at the number of applications they had. And we ended up with 3 almost equally sized groups with 1 to 4, 5 to 10, and more than 10 applications.
I see. And you looked like there was a relationship between the number of exposures and the increase in T1 signal intensity changes. And were the ratios that you got, were those with this agent, were they comparable to the ratios others had reported using similar techniques with other agents?
Yeah, we tried to copy the measurement technique, the raw drawing, and the sequences and all that from the studies we know so far to make it comparable. But a direct comparison of the elevation of these ratios is quite difficult because the other papers do not show the data in such a great detail that head-to-head comparison would be possible.
Okay. Now, what about in the interval since you put this together, have you done any further analysis with some additional patients to look, because 2 groups with the lower levels exposure didn't actually have a statistically significant increase in the dentate nucleus signal intensity. So, but the problem there may have been the power. And so the question is if you have sort of added and if the lack of statistical significance persists, or are they significant as well?
So in the lower group, I don't think that we will ever reach a significant level because this is too equal to those patients who were never having gadolinium-based agent. In the other 2 groups, we saw an elevation. We saw it visually as well, especially when patients approach 8 or 9 applications in the past. But I think that's especially in the group 2 with 5 to 10 applications a matter of cohort size, of a sample size. And if we increase this sample, then we're going to reach significant values as well, as I assume. But most importantly, it depends also on the mathematical parameters in such a setting. And if you do unadjusted tests, for example, at the level of 0.05, you will reach significance also in this group. Only in the adjusted Bonferroni home-corrected data set, non-significant. So this is mathematical stuff, and I think the problem here is rather the power of the study and the study setting.
Yeah.
A study which is not powered to prove
Right.
equality and not powered to prove the significance in such a small cohort.
Right. Okay, Dr. Tweedle, as our go-to guy, at least my go-to guy frequently, any surprises with this study? What do you see as the takeaways?
This molecule that was studied, drug that was studied, is based on the same chelating agent as Magnavist uses, the gadolinium DTPA, but with an appended group that greatly increases the protein binding. So if it turns out that first group with less than 5 injections had no signal detectable, turns out with many studies to be of a lower order of signal intensity increase than Magnavist, I would say probably the protein binding is removing from crossing the blood-brain barrier of some of the chelating agents.
Good.
But otherwise, it's not surprising. This is a well-done study and welcome.
Great. Thank you both. Dr. Radbrook, are you still paying attention?
Of course, very much. Yeah.
Okay, well, you and your colleagues published a study, no signal intensity increase in the dentate nucleus on unenhanced T1-weighted MR images after more than 20 serial injections of macrocyclic gadolinium-based contrast agents. So I don't have to ask you what you found. It's right in the title.
Absolutely.
But I do have to ask you, why did you decide to do this study? There's already a lot of evidence that patients receiving macrocyclics don't show an increase in signal intensity in the dentate nucleus, for example. So why did you decide to go through what was obviously a lot of work?
Because actually, if you ask patients and doctors, they will tell you, well, like it has not been shown yet for macrocyclics. And so actually, like there was a very important study also published in Radiology by the Martin Prinz group that assessed more than 35 injections of linears. And what we learned from this group is there's actually not only the dentate nucleus, but more structures in the brain that started to be hyperintense the more linear agents we inject. And so there was a question for us, after a very high number of injections of macrocyclics, will we find something or will we not? And our hypothesis, that's very important, was driven by an idea about the physiology, about the mechanism. And so actually there were 2 papers published that I really want to mention here that are extremely important for the further discussion. It's crucial to actually differentiate between dechelation and presence. Yes. And I think this is something that is mixed up in the current discussion very often. There's no doubt that macrocyclics are present in the brain. A different question is if there's dechelation. So there was actually a study showing that immediately after injection, and it doesn't matter which contrast agent, like they assessed 3 linears and 2 macrocyclics in the study by Joost et al., published in European Radiology. They found the same amount 1 day after injection of those agents for all. It doesn't matter if linear or macrocyclics. So immediately after injection, we've got the same amount for macrocyclics and linears for those assessed in the brain. So, but 4 weeks later, like there was a significant difference. And one study, it was published 2 weeks ago by Joost et al., they showed that actually for the linears, it was found that there were complexes found like insoluble gadolinium and gadolinium bound for macromolecules. That was not shown for the macrocyclics. So actually, the reason why there are differences between the macrocyclics and the linears is not the presence. It seems to be the dechelation. And our hypothesis was like, we would, if that is true, like if really the dechelation matters, we would not see anything due to the high kinetic stability, even after a very high number of injections. And that is actually also what we found. And if this hypothesis is correct, and I would do a bold statement here to make the discussion a little bit more lively, I would project that we will never see any hyperintensities after exclusive usage of macrocyclics above a limit of detection. But it's a bold hypothesis. So we've proven this so far.
I think it's an interesting statement, but it goes a bit beyond the scope of your study, and I think it's a little difficult to jump to conclusions based on the little bits of data that we have. Now, why did you decide to lump all macrocyclics? They're not all the same.
Well, actually, that was a matter of what was available on the department. Actually, we changed from linears to macrocyclics about 5 years ago when we first changed to Gadavis and then to Dodorem. And actually, again, this whole study was driven by the hypothesis that there is this
Oops.
And that we can see in
I think you're breaking up. Dr. Roderick, I think you're breaking up, so we're going to have to keep moving along. How did
am I here again?
Now I hear you. So how did you deal with the issue of prior gadolinium-based contrast MR exams? Because you had patients that had prior linear agents, I believe.
Absolutely. And that's, again, it's important. Like we performed subgroup analysis there, and we published a prior study where we showed that actually, if there are hyperintensities that are caused by linears, in fact, we found that those, if we change to macrocyclic, those might decrease over time a little bit. And so it is an important bias that you have to take into consideration as an important confounder. But the point is here, and that is very important to understand, if the theory that those hyperintensities depend on gadolinium bound to macromolecules or insoluble gadolinium, like if those hyperintensities really depend on that, this would mean that a decrease could be caused by either washout or a change from the gadolinium bound to macromolecules to, for example, gadolinium phosphate. That would also cause a decrease of the signal, and without that, the gadolinium would disappear from the tissue. And let me add, I think, so the question is which one is correct? Let me add like one consideration we also did in our study. I think one important factor is in the original study by Bob McDonald, we found a very, very strong correlation between the gadolinium, the amount of gadolinium injected and the gadolinium found in the brain. So that would at least speak against a real high washout of the dechelated gadolinium. But again, for the washout, it's important to differentiate between the dechelated gadolinium and the chelated. So to answer your question,
there's been relatively little quantitative assessment of the form of the gadolinium. I mean, the McDonald study was very small. I mean, I think we're really at the beginning of our understanding. But since you raised it, one of the concerns that were raised with your study is it was also, of course, underpowered. And the concern that the pre-existing gadolinium may have obscured the deposition. So the washout of the gadolinium that had been previously given, there might be accumulation that in the ratio measurement might not appear as any change, whereas in fact there might be deposition from the macrocyclics. And this is the general question that Dr. Evans and colleagues raised regarding the washout. And we'll get to that momentarily.
Yeah. So again, like we perform subgroup analysis, but I think it's very important to understand really that we are talking about two different kinds of washouts. First of all, we have to really figure on like if it's dechelated gadolinium or not. Like Dr. Evans did a great job in showing that, we will hear about this in a minute, that we will that we will find a washout over time of the whole gadolinium. Actually, I think what really matters is the small part of gadolinium that is released, that is bound to macromolecules, that is, according to the last published study, causing the hyperintensities. And that is really something we have to differentiate. We have a washout of the whole chelate.
That may be the case, but we don't, from your study, we're just looking at T1 weighted changes. We have
Totally
no
correct.
idea whether or not there's the absence of T1 weighted changes because gadolinium is hiding or gadolinium is there and it's just replacing gadolinium that left. So I think your points are of interest, but it doesn't really relate to your study. Let's start with Dr. Evans and Dr. Tweedle. What do you think about the role of washout in the study by Dr. Radbrook and colleagues? Could there be a possibility that the washout of the linear agents is obscuring the accumulation of the macrocyclics? Dr. Evans?
Yeah, I think that's an important consideration. Of course, we have to remember, just because you don't see hyperintensity on MR imaging doesn't mean that gadolinium isn't present.
Sure.
Dr. Radbrook raises a good point about the different forms that might be present. But it's also the case, I think, that we can't treat these agents the same. Even within the macrocyclic class, there are differences between them. Though I'm aware of emerging data, for example, Dr. McDonald presented at ASNR to show that actually with one macrocyclic agent, you can see gadolinium present in brain, and also you can see T1 hyperintensity in a rat model, and that was with Gadavist, for example. We're also aware of other emerging data from multiple independent clinical studies, which are beginning to show that with certain macrocyclics, again, you can see T1 hyperintensity in humans. And again, that was with Gadavist. And in McDonald's work, I think that's ongoing, he's showing differences between say Gadavist and Prohance, for example. So I think to treat them all the same is not correct, and we really need to understand how they're acting within the brain. And again, we're thinking about decalation. There is work showing binding to macromolecules, for example, but again, that isn't definitive proof of decalation. And in fact, seeing the hyperintensities with certain macrocyclic agents does beg the question whether this is true decalation or some other effect, for example, the chelate itself binding to macromolecules and different interactions with tissues that are going on.
Sure. Dr. Tweedle, what is your take on this stuff?
Well, I was glad to see a non-ionic macrocycle and an ionic macrocycle have exactly the same results, because it's something that I've been pondering for some time. While it's true that the macrocycle, the three of them, are not exactly the same, they have the same fundamental core to them, which is in fact in laboratory setting responsible for their very, very slow kinetics. I mean, one speciation study, albeit not a strong study, did find a macrocycle left in a patient 8 years later intact. It's not that these things will last forever. It's just that on the full scale of all of the molecules, the differences between the macrocycles and the linears, I think, is a lot more than the difference among the macrocycles or among the linears.
Mm-hmm. Good. Okay, Dr. Evans, you and your colleagues at Amersham reported on the clearance of gadolinium from the brain without pathologic effects after repeated administration of Omniscan in healthy rats, an analytical and histological study. So can you tell us sort of what you did and what you found in your study? We've been sort of dancing around it a bit.
Yeah, sure. So when we embarked on this work, we really wanted to understand if the gadolinium present in the brain, the levels change with time, but also whether there was any potential adverse effects on neuronal tissue as well. And we elected to use a rat model for this. Of course, in preclinical research, you can control very well confounding factors that may cause problems in clinical studies. For example, you have full control of the type of contrast administered, you can have full control of the dose, and also the time since last exposure. So, in full control of that, we were able to study in some detail the kinetics of gadolinium in the brain with time. And the way we did this was we had animals, or two different dose groups. We had a high dose group who got 20 repeat doses of, and this was gadolinium Omniscan over a 5-week period, and we had a lower dose group who received 10 repeat doses over that 5-week period. And then what we did was two key time points, the first being 1 week after the last dose, and the second being 20 weeks after the final dose. We sacrificed the animals by perfusion fixation. And that's important because that enables you to remove any residual blood from the brain. You know you're focusing on gadolinium that's actually present in brain tissue. And also because you're fixing the brain at the time of death, you get very high quality tissue for morphological analysis. And so at those time points, we took the brains, and half of the brain bisected down the midline went for ICP-MS analysis of gadolinium levels, and the other half went for a toxicologic histopathology analysis throughout the brain, including several key regions. And what we showed that gadolinium was, of course, present in the brain after administration, and that was clearly dose-related. So with a doubling of dose, we saw an approximate doubling in the level of GAD present. But one thing we noted was when you looked at the amounts retained in the whole brain of the rat compared to the total injected gadolinium, it was a very small fraction of what we actually injected. So it was equating to around 1/1,000,000th of the total injected gadolinium dose. But a key finding really was, as I alluded to earlier and we've been discussing, when you compared the levels of gadolinium at 1 week after the last dose to 20, there was a clear reduction in the level of gadolinium present. So it reduced by approximately 50%. And that's important because it shows that much of the gadolinium there over that time frame is available for clearance from the brain over the weeks to months after exposure. And more importantly, I think the toxicologic histopathology analysis showed no evidence of any cell damage or adverse tissue effects at those time points. And remember, the gadolinium has been present in the brain for up to 6 months at the final time point.
Right. Now, a couple of questions. Did you look at the form of the gadolinium, whether it was bound or unbound, in your study?
We didn't in the current study, no. Of course, as I'm sure everybody knows, it's a very difficult thing to do.
Right.
You know, once you start extracting from tissue, then there's the danger of sort of affecting the chelate itself through the processing. But we are thinking about that moving forward, thinking about different methods, even to potentially look at the form in situ in a tissue, but not in the current study, no.
It sounds like that's kind of the heart of the problem. We'll get to sort of this later. But my other concern was, is histopathology the optimal way to look at these kind of toxic effects? Because people are concerned about functional alterations. It's a calcium competitor. It could interfere where calcium is part of a coenzyme or affect function of the mitochondria. There are a whole host of things that have been invoked as potentials. And it would seem to me that not all of these would necessarily affect the histopathology over a 20-week period.
I think that's a fair comment. You know, our histopathology analysis was a first step. It's, of course, the standard approach used in safety assessment during drug development. So we thought it was important to do a full survey of the brain, as we would do in that setting. But of course, it's one endpoint, and I think, you know, we have ongoing work to look at multiple endpoints. As you said, mitochondria, ultrastructure, and other aspects in the future to try and add to the weight of evidence, if you like. It's hard to prove a negative, but I think the more evidence we can have showing a lack of harm, the more confident we can be.
Sure. And this issue, the question that I always find nagging, and I'll ask both you, Dr. Evans, and Dr. Tweedle, why do you think gadolinium deposition wasn't reported in the earlier preclinical tox studies that preceded the approval of these agents? Dr. Evans?
I doubt that it was looked for at any really low level.
Okay, so, but I mean, I would think the FDA, that's like the most important thing they want to know is that the whole thing is cleared.
At what level is
okay.
the question. And I was there and participating in development, and they were quite impressed with the radioactive gadolinium studies that we did when we developed one of these agents, and got down into fractions of 1% of the
Right. So that goes to Dr. Evans' findings that we're sort of dealing in the millions.
I think that's true, and you know the sensitivity of techniques now has moved on so much in the past 20 or 30 years that we're able to detect such low levels that possibly weren't possible, you know, during the original development of these agents.
Good.
But speaking of low levels, we have to remember that if you see it at all in the MRI, you pretty much have to be in micromolar.
Yeah. Well, that's sort of
considerably more than protein concentrations.
right.
Yeah.
So that, I mean, to me, that's the most striking thing, because if it's visible, it's just odd that we're learning about it 20 or 30 years later.
We may well be seeing the chelated form.
I see.
Others could be silent.
Right. Good point. Dr. Canal.
Well, I think after listening to all this,
Where are we going? What have we learned today? Where does this information fit in to the big picture of our understanding? And how should people who are watching this, how should they fit this information into their fund of knowledge and potentially into their behaviors?
there are several things that I think today's podcast has helped bring to light and to help solidify. We're talking about what we can see and what we can't see and what form is it or isn't it. So I'm going to return to my opening statement and try to reiterate that the more we learn about it, the more we recognize how little we still know about exactly what's going on. What form is it in? In fact, Dr. Tweedle, I understand what you just said, but I believe that many people have felt that the concentrations reported, the highest concentrations reported by McDonald and Kanda in their autopsies, and there are only a few dozen in the world today on humans that we've got data on in the first place, is insufficient for us to see. Those quantities at the highest levels they've seen are insufficient for us to see on MRI. So based on standard T1 weighted imaging sequences, we have to assume that they're neither precipitate nor in their original forms, but more likely in a bound to macromolecular form, which means that there's still a massive amount that we don't understand. Dr. Evans had a tremendous point, which for the past 2.5 years, those that take my safety courses have heard me ranting and raving that attempting to lump together linears as if they're all the same, macrocyclics as if they're all the same. We're doing the exact same, please pardon my bluntness, errors that the industry and the FDA has tried to do for NSF when it first came out. And it didn't work then, and the data does not support our doing so today. There seem to be substantial differences amongst the linear agents, and there seem to be substantial potential differences that we're starting to see amongst the macrocyclic agents. But I can't help but feel that our industry is trying to force reality to meet our theories once again, instead of adjusting our theories to meet reality. In addition, this entire podcast is about intracranial contrast, but recognizing that the intracranial concentration is a small concentration of what's left in the bone, a small concentration of what may be present in skin, let alone if patients have poor renal function. And this is only patients with good normal renal function. And to say that it's 1/1,000,000th the total administered dose may be appropriate for a specific location in the brain, but I'd be more interested in the number as to what's retained in the entire body. And what's retained in a potential phosphate reservoir, for example, in bone, is to me much more important than what might be present in just a single unilateral dentate nucleus. In addition, and finally, I think it's important that we recognize that we talked about it crossing the blood-brain barrier and the potential for doing so with protein. I think we have ample data to suggest now that there is much, much more likely that these do not likely cross the blood-brain barrier and instead are going through the glymphatic system or the CSF pathways, and that's hardly been discussed whatsoever in the literature, but yet for years we've known that this pathway exists, and we're able to document it exists, especially for those who, for example, inadvertently received intrathecal administration. So I think there's a tremendous amount here that we still don't know. Much of the data, with tremendous respect to the individuals on this podcast, much of the data still deals with a few dozen patients at best. There's a lot we need to understand before we make sound conclusions and broad sweeping recommendations, in my opinion.
Well, thank you. Now we'd like to hear from the rest of our panel. I'll go around to everyone. What are the important questions that you think we still need to answer, and any thoughts about how we should go about doing this? It's, sitting here as an editor, I'm struck by the potential importance of the issue, and just kind of the exploratory nature of the data that we're getting. It's kind of, it's going to take us a while to sort this out, I fear. Dr. Deneke, what do you think are the most important issues we should be looking at, and any suggestions as to how we might go about it?
Yeah, as you said, it looks like a big puzzle, and the study we did was just a small contribution. And I think the image of the whole puzzle when it comes together is whether there is any clinical effect.
Sure.
Or as we know, we don't see any, but this should be investigated, even though it's very difficult to do so.
Well, particularly, I mean, think about it. If you don't know what you're looking for, okay, we're getting it by these, retrospective samples that are largely confounded, it's going to take a long time. I just worry that we are not organized to collect enough data. This is somewhere I think big data could really play a role. And I'm not aware of anyone that's marshaling the resources required to address it in that way. Dr. Radbrook, what do you think we should be working on? What are the important questions that remain?
Yeah, well, obviously the most important question are the clinical correlates. And I think it's really very important for us as radiologists to come here together and to say our patients that no consequences are known yet. And it's really, I think personally, it is extremely important to get this, to rationalize, to de-emotionalize this whole debate, and to really calm patients and tell them we don't know anything and we should not be concerned at all. I think that's a very important message.
Well, there is a difference between not knowing and not being concerned. I think it's fair to say there has been no proof of any adverse clinical outcome related to gadolinium administration.
I totally agree.
The proof doesn't mean that it's not an issue.
I totally agree. And so that is the question, like what we could do. And yeah. I'm gonna play devil's advocate. Again, the scientific discussion is always interesting if there are different opinions. And my personal opinion is like based on the current new studies available from the use from the Peach group that has been published 1 week ago. I think there is a lot of evidence that actually the hyperintensities depend on the dechelation, and there is a lot of evidence that there is in fact the major effect is a class effect, and there might be still differences between the macro-6 and linears that have to be exploited, of course, in future study. But I think on the data that is available right now on a pathological basis, the main differences between linears and macrocyclics, and that the hyperintensities that we find in the brain actually correlate in the end of the day to the stability, what we find also in vitro. Of course, there are still things that have to be enlightened. I think currently there is a lot of evidence that is in fact a class effect. And I don't want to give any recommendations, but I think those are the two important points. First of all, don't concern patients unnecessary. And second of all, acknowledge that there is, in fact, difference between dechelation and presence. Macrocyclic are presence, but shouldn't we, like from a toxicological point of view, be more concerned at the end of the day about dechelation than about the presence of the chelate? So there are still a number of issues that have to be debated. Again, I think we really have to, in future studies, really focus on studies that assess dechelated gadolinium instead of mixing like the chelated and the dechelated form up. I think that's crucial. But so,
well, as you were speaking, I see Dr. Evans and Dr. Tweedle with varying levels of grimace. So, Dr. Evans, you can start. Okay, so we'll have 3 grimaces, and then we'll sign off. What are you grimacing about, Dr. Evans?
I was just thinking, I think I'm going to have to gracefully disagree with Dr. Radbrook. I think that to ascribe this simply just to dechelation is a gross oversimplification. And there must be other things going on, other factors. And I think, as the data evolves over the coming years, we're going to see, the delineation between macrocyclics and linear is not so big. And I think we're going to understand that there's more to this than simple decalation. And T1 hyperintensity and presence in the brain is going to be something that is going to be seen with many, if not all, these agents to some extent.
Dr. Tweedle?
Well, it certainly wasn't seen by Dr. Radbrook in a set of patients that got quite a large number of macrocyclic agents. I think we need more neurotolerance studies in animals. You have to start in animals for this. And it's well known in animals, if you use a radio tracer, that between 7 and 28 days, there's not a change in washout of injected solubilized free gadolinium. So I'm afraid I'm on the side of thinking that there's going to be a large difference in clearance rate between free gadolinium and chelated gadolinium. Not that there's no clearance of free gadolinium.
Yeah.
And so we need to understand the neurotolerance of both chelates and the dechelated gadolinium.
Thank you.
I agree. And if I could just chip in. So we are embarking on studies, working with others actually, to look at neurological functional tests in animals.
Great.
Particularly focused on memory, cognition, and motor skills. We are going to begin looking at that, and we accept that there may be more subtle effects that maybe you can't see on histopathology that really need functional tests to really look into more detail.
Great.
And if I may, two other points I just want to make sure we get in before we close. And that's that the idea that there's less toxicity because it's in its initial form, there certainly can be neurotoxicity for the intact chelate and perhaps less neurotoxicity for insoluble precipitates. And second of all, the idea that the entire podcast is now over and we've never discussed the concept of relative relaxivities, and the idea that what we're seeing and how much of a relaxivity may be present with one agent versus another may make a difference in what you're measuring or perceiving that you're measuring, let alone if there's dechelation and let alone if there's reconstitution with a new macromolecule. So again, trying to put too much on whether or not you do see it, especially again for Dr. Radbrook saying again all macrocyclics, when we know now that there are certain macrocyclics that seem to behave different from others. I would like to go back and suggest that I am not nearly as confident as others are that we could make broad statements at this stage.
Well, this is an exciting discussion, but it will have to come to an end. You realize, Dr. Canal, the president of our country decides to tweet 170 characters as a major method of communication. So I worry that our listeners may have lost their ability to pay attention for this discussion. But I want to thank you all. I think it was very, very stimulating. Thank you for the papers, and thank you for your interest in our journal. Thanks.
Thank you very much.
Bye-bye.
Thanks so much.
Thank you.
Thanks so much.
Hello, this is Albert de Roos. I'm the deputy editor for cardiac imaging with radiology, and I'm joined today by the author of an interesting article on DNA damage from MRI studies. The article is entitled Impact of in vivo high field and ultra field MRI on DNA double-strand break formation in human lymphocytes. The senior author is Dr. Björn Friebe from Magdeburg University. Welcome, Dr. Friebe.
Hello, welcome. It's a pleasure to be here.
Thank you. So we are very interested in your article, which will be published soon, and to explain the background and controversies with these safety issues related to MRI and possible DNA damage. Perhaps you can start to explain a little bit the background, what has been published, and what the controversial issues are at this moment.
Of course, sure. Our work our topic is like a part of a big discussion going on right now in MR research, or let's better say environmental research. And the question came up whether the rising exposure of electromagnetic fields, from different technical installations like mobile phones or Wi-Fi nets that are part of our daily routine life, if they can harm DNA integrity of humans, and in this sense also falls MRI. Of course, we know that MRI is a very powerful diagnostic tool, and the numbers of MRI examinations still are worldwide constantly rising, and different techniques, functional, anatomic imaging, whatever, even in developing countries, there are new scanners being installed, and so in this context is our topic seen if the electromagnetic fields of MRI do cause damage to human DNA.
So, and what was actually the controversial publications until now in MRI particular?
Mm-hmm.
Can you explain that a little bit, the setting here?
Yeah, of course. So far, one has to say that there's only very limited data available. And there were some groups some years ago, they began to investigate this problem by a new or relatively new assay, a very sensitive cell assay that can show double-strand breaks in DNA. It's called the gamma H2X assay. And there was a study some years ago by a Swiss group, and there was proposed that there was a rise in double-strand breaks just after cardiac MRI examination. And this finding also led us to start investigating MR exposure via the detection of double-strand breaks through gamma H2X.
Okay, so that's the setting. So, and there have been a number of publications in this regard, as you discuss in your paper too. But what was now the actual purpose of your study? You have experience with 7 Tesla MRI in your institution. So you went one step further to include different field strengths. What was the actual purpose of your study?
Of course, as I just said, there's only very limited data available. And this limited data is very different also in the experimental settings. Some groups examined the effects with contrast media, for example, which obviously is a big issue right now at the moment. Also, some without, then different field strengths, different MR examination methods like cardiac imaging or whatever. And as you said, here in Magdeburg, we have the possibility of ultra-high field MRI at 7 Tesla, which we assume if there would be an effect that we could like provoke it in a stronger way, because we know that an ultra-high field MRI, of course, the energy level that are deposited in the subject are much higher than in lower field strength.
So you did a comparison of 1.5 Tesla, 3 Tesla, and 7 Tesla.
Exactly.
In a number of subgroups of patients who underwent a clinical MR study. Mm-hmm. And what were the main findings from this study? What was your main conclusion?
Our main conclusion was that under the given setting that we did, we had 4 field strength, including 1, you forgot 1 Tesla. We had 1 Tesla, 1.5, 3 Tesla, and 7 Tesla. Every group with contrast media and without contrast media. And our main finding was that the exposure through clinical MRI examination didn't provoke a rise in the double-strand breaks of the subjects just after the examination. We had different time points. We examined just before the examination, then immediately after the examination, and then 30 minutes after the examination. And we revealed no increase in DNA double-strand breaks.
So that was your conclusion, that up to 7 Tesla there were no DNA changes detectable.
Exactly.
in your setting. So, but in all these articles there are little details we have to look at, and I looked at some of them in your paper, and I like to have your feedback and how to contrast them with the literature. So, for example, the baseline values of these changes of DNA are important to recognize that there is a lot of variability, as I understand it. And you corrected for this heterogeneity at baseline by normalizing the values and to look at relative changes. How important is this correction and this attention to detail of addressing the variability at baseline? Can you comment a little bit on that?
Sure. In our opinion, it's very important because, as you already mentioned, the baseline level, on the one hand, it's not really known because it's also part of this limited data that you cannot really tell. But like we observed, it's on a very, very low level. I mean, we're talking about a mean foci number of gamma H2X of around about 0.05 to let's say 0.1 or maximum 0.2 foci per cell, and there's a big variety also in our negative controls that are also other groups have revealed it, but the important thing would be if you are exposed under MR, the relative increase of the double-strand breaks. So that's why we normalized it to the individual levels of the double-strand breaks before the examination. Because yeah, I don't know if I should continue. The thing is, also in healthy humans, it is well known that you have double-strand breaks, and it can be influenced by a lot of other agents, and it's a stable state between induction of double-strand breaks and also repair mechanism of double-strand breaks. So that is why there's such a large variety.
Yeah. And actually, from your control group using CT, it was clear that you could measure an effect from X-ray radiation. So that confirms
exactly. Yeah,
that this technique is working well.
Exactly. There's another important point. You have to include control groups, positive and better negative control groups, to show that there's a strong effect.
So most of these studies, and also your study, used relatively small sample sizes. You think that's statistically okay?
Well, we all know that a big sample size improves a study a lot. We have started doing this by the year of 2013. It's a big effort also of laboratory work. In this sense, we can say that we are glad to have a fully automated immunofluorescence microscope, which helped us a lot. And of course, a bigger sample size would be nice, but I think yeah, that all groups have not that large sizes is also a sign that of the big effort that has to be taken in the laboratory.
So also the counting of these abnormalities is an issue, and you mentioned automated digital microscopy as a valid method. And I think in previous publications, this assessment was mostly performed by visual inspection.
Exactly.
Do you expect that that will be a confounding factor for reproducibility when you take an automated method versus a visual method? Is that an advancement?
No, our system was previously, as you said, in various studies validated, and it was equal in terms of the quality of the detection, and helped us a lot, as I said, because it's very demanding to look it up visually only. So I don't think there would be a confounding factor.
So one other aspect which is quite intriguing is the time points of sampling after the MR examination. So people did early sampling, 5 minutes, 30 minutes, up to 1 week or even 1 month, I believe, in other publications. So, and sometimes there have been early changes. Sometimes they only detected change after 2 weeks or even 1 month. So that sounds all quite controversial. Can you comment a little bit on these sampling time points and how important they are, and whether we can expect a biological effect early or late, and what would be reasonable in this sense?
Yeah. As I said, double-strand breaks are also present in healthy human beings, and there's a constant balance between the induction of double-strand breaks and repair mechanisms. And what we know is how, when we looked up how this method works, the gamma H2X assay has been validated in ionizing radiation, like with after CT examination, and there we can estimate the repair dynamics, and there you can see that the highest level is like just immediately after, like half an hour after the exposure, and then you can count that 24 hours later all this increase has gone, so it has been repaired. So this acute or immediate exposure is the most important thing. On the other hand, the prolonged effects, we did also a study on occupational MR exposure, where we could see that a group with for years a constantly repeatedly MR exposures through 7 Tesla did not reveal increased double-strand break level. So in our opinion, the most important thing would be the immediate exposure and an early time point, because we cannot know what in much later time points will happen, or what the cause there will be.
Okay, so this is an interesting topic, and you provided some interesting insight into your methods and your analysis and your results. And we will see how this discussion will continue over time. And I'd like to thank you for your contribution. Thank you very much.
Thank you very much. Thank you for having me.